Hi, I'm Dr. Omar Bey, and we are the Physicians Health Network, I should say. All right, we're a group of physicians that's here to answer your medical questions. It's all about health and wealth, and wealth is good, but health is better. And I always say that. So we want to put it together and answer your medical questions. The focus is on education, health education. And we're here not to be your physicians, but we're here to answer your questions so that you can have a better understanding about your health. All righty. I would like to definitely say, and this is so important, and I will repeat this several times during the program. Do not change any aspect of your medical care before you consult your physician. Reason being is that your physician is the best one to know what your medical condition is and how to treat it. And no matter what we say, we're here for general medical education, please. All right. I would like to thank OBHealthy, which is our sponsor, for allowing us to use their platform to bring this webinar to you, number one. And just to give a short little understanding of who they are, OBHealthy is a weight loss app, and they are geared for better health, number one, through weight loss. And in the African American community, that is something we need so much that they have put together a program with soul food, Caribbean, Latin, and 30-day meal plans. So just download their app, check them out. We're so glad that they allow us to bring this forum to you. I think that's just about it. I don't think I forgot anything. What we need to do is we need to get started, because there is a lot happening in our community at this particular point. Let me lay out the program. Initially today, we had one guest, but because of COVID and the fact that the vaccine is about to be implemented in this country, we have Dr. Graves coming on, and he will be here at 2 o'clock. And he will sign on to answer any question about COVID, about the vaccine. So it's so important. If you sign on, stay with us today, because we're here to answer those questions. But first, we have Dr. Andrew Badu, and he will introduce himself. He's a renal specialist, a kidney specialist. And that means that he can answer any problems that we have out there with our kidneys and how kidneys are related to other diseases as well. So let's get started. The first thing I'd like to do is I'd like to introduce our distinguished physician panel here. And I would like to start, and I'm going to go with the order that's on my screen. Dr. Court, can you please introduce yourself?
Good afternoon. My name is Dr. James Court. My specialty is internal medicine. I treat adults. My office is located in East Orange, New Jersey.
All righty. And Dr. Atherley.
Hi, my name is Trevor Allen. I'm an interventional cardiologist. I am based primarily in Newark, New Jersey. And in addition to my zeal for treating patients, I also am part of the teaching faculty at Newark Beth Israel Medical Center.
Right. Dr. Kendall Sprott. Please unmute yourself, Kendall. Can you unmute yourself? Thank you.
My name is Kendall Sprott. My background is in pediatrics. I did general pediatrics and pediatric critical care.
All righty. And Dr. Dwayne Fredericks, you have to unmute yourself as well.
I'm unmute. Dr. Dwayne Fredericks, I'm a bariatric surgeon. I actually do medical management for weight loss. And so that's a big thing for me, taking care of that. I practice in South Orange, New Jersey.
All righty. Thank you. Dr. Patrick Anderson.
Thanks for having me. I'm Patrick Anderson. I'm GYN oncology, gynecologic oncology at Newark Beth Israel Medical Center. And like Dr. Atherley, I do take care of women with cancer, and I'm also part of the teaching faculty at Newark Beth Israel Medical Center.
All righty. Thank you. Dr. James Lee.
Good afternoon, James Lee Jr. I'm a second-generation orthopedic surgeon, community orthopedic surgeon based in Essex County. I'm also teaching faculty at Newark Beth Israel Medical Center.
All righty. And Dr. Andrew Badu, he's our special guest today.
Good afternoon, everyone. My name is Andrew Badu. I'm a nephrologist, also known as a kidney specialist. I'm based in Essex County, Office is in East Orange General Hospital.
All righty. Thank you. And Dr. Kareem Salam.
Good afternoon, everyone. My name is Dr. Kareem Salam. I work in the city of brotherly love and sisterly affection known as Philadelphia. I am on the clinical faculty of Drexel University College of Medicine, and I'm a board certified adult and child and adolescent psychiatrist. I'm the medical director of an adolescent unit in a hospital in Northeast Philadelphia. Moreover, I'm one of the founding members of Global Health Psychiatry, and we publish mental health literature that focuses on attacking stigma as it applies to mental health conditions in the African American community. And it's such a joy to be with you.
All righty. Thank you, brother. Thank you. I'm Dr. Omar Bey. I'm a pulmonary critical care physician and with a specialty in nutrition. I am the director of nutritional support at one of the larger hospitals in the Newark area. All right. What I'd like to do is I'd like to start with Dr. Badu. Dr. Badu, you are our guest today, and many people have been sending in questions as far as kidney is concerned. What I'd like you to do is I'm going to ask a question. If you could just give us an understanding, just to start off with, what does the kidney do for the body?
Yeah, Dr. Bey, well, kidney disease is a disease that is very prevalent in our community, unfortunately. And it's a disease that we clearly need more understanding on. And as you indicated, what is kidneys and what is the function of the kidney? Every one of us has two kidneys, in most part, unless you are born with just one. But in most part, majority of people have two kidneys. The kidneys are basically located in the back of your body. You could imagine being around just underneath your rib cage on both sides. And the kidneys function basically to try to cleanse the system, to remove a lot of the impurities that develop day by day. And that's the basic essence of the kidney. There's other functions that is included with that, but the essence of it is really to try to cleanse the system.
All right. All righty. The thing of it is that the question that came through is, and I'll read it here. My doctor keeps saying that my BUN and creatinine is elevated. Can you explain what that means?
The BUN and creatinine is a way of us as physicians to try to assess how the kidneys are working. Now, the BUN is basically a byproduct of protein breakdown, which goes to the liver. And after that, it goes to the kidney to be cleared. And as I may have indicated, the kidney serves as a sense of filtering the body. So when the BUN starts increasing, it becomes an indication that the body is not being cleansed appropriately. So it becomes the first warning sign of kidney problems. But it's not just indication of kidney disease, because other things could also cause your BUN to go up, as much as like simple dehydration. But in essence, an elevation in BUN and creatinine may suggest possible kidney disease.
Mm-hmm. Okay, excellent, excellent. So that's the way the doctor kind of follows and understands how the kidney is doing, the health of the kidney.
Correct, because essentially, if you have something wrong with your kidney, there's no way for you as a person to know. The only way you will know is by a basic blood test.
Mm-hmm. Basic blood test. Okay. I'm going to deviate from you just a minute because a question came in for cardiology, Dr. Atherley, and we'll get back to renal in a minute. It said, good day. There is a routine test that one can request that will tell a person if one's arteries or the heart or in the heart or the brain are narrowing, indicating the possibility of a heart attack or stroke, a stroke ahead of time. Will a daily dose of aspirin prevent blockage of the arteries? Dr. Atherley?
There are several questions there.
Yeah.
Yes, thank you. There are several questions that I see you've articulated. The first relates to testing of the heart. Well, the heart is a very complex organ, and we test various aspects of its structure and its function. So a lot depends on what symptoms the patient has and how we want to direct our tests to elucidate whether or not those symptoms are related to the heart. For example, in patients who are having chest pain, There may be the need to check to see if the chest pain is as a consequence of heart disease. And I consider that the most serious form of chronic chronic chest pain. What we look for that might be causing the chest pain is to see whether the arteries to the heart are blocked. Now, what do these arteries do? The heart, as you know, is a very powerful muscle. It pumps about 20,000 gallons of blood through the course of the day. Very, very powerful. In fact, the most powerful muscle that we have. To supply the needs of the heart itself, there are tiny arteries which run on the surface of the heart called the coronary arteries. If these become blocked and are unable to deliver the blood that the heart needs, the heart muscle, in a sense, suffers and may demonstrate this by virtue of pain. So if you present to your physician with chest pain, he may decide not only on a physical examination and on asking you questions, but he may decide on certain specific tests that may be done. Now, the simplest and the most routine of these tests is an EKG. Electrocardiogram tells us the electrical activity of the heart muscle, and this electrical activity may be affected by actual damage or impending damage to the heart muscle. So that would be one of the simplest that would be done, one of the simplest tests. Again, looking at these coronary arteries, if there is still a suspicion of there being the cause of the patient's pain, but the EKG is not given the full answer, then you may exercise the patient, do what's called a stress test. This is working the heart a little harder. We can do in several ways, but the commonest, of course, is exercise on the treadmill. As we exercise the heart, we look to see whether the electrocardiogram, which is being monitored for the heart, demonstrates findings, changes, which may indicate, again, the heart muscle is not getting enough blood. We've added some sophistication of these, and you may have what's called a nuclear stress test. That is, where a radionuclide may be injected, and it will show a difference in the way the blood perfuses or goes through the heart muscle with exercise and at rest. So that's a nuclear stress test. It's a sophistication of simple stress tests. And there are a lot of varieties on this, giving different things to stimulate the heart as opposed to exercise, and different ways of measurement using echocardiograms, etc. But from the point of view of time, I just want to address the evaluation of chest pain. If the stress test yields specific abnormalities that suggest that the arteries are blocked, then there may be need to further elicit the severity and location of these blockages so that we can appropriately go in and take care of those blockages. Leaving the blockages unabated, untreated, may lead to further consequences such as heart attacks and death, etc. So we continue the escalation of evaluation of this simple chest pain which the patient may have presented with, chest pain or even a heart attack, but we may then have to do a cardiac catheterization, and that involves passing tubes through one of the arteries in the heart. The usual ways of accessing these are either arteries at the wrist, the radial, or arteries in the groin, the upper leg area, the femoral, and pass these tubes back through the arteries, inject dye, looking under X-ray visualization, inject dye into the coronary arteries, and then we can see more directly whether or not the arteries are blocked. Again, at that point, the advantage of this is that if we see blockages, we can go ahead and fix them. I'm not going to go into the details of how we fix them. But there are many aspects. There are even others that I could mention. Coronary CTAs, you may be told about, CAT scans of the heart, etc. There are many ways in which we evaluate the heart, but essentially the evaluation is based upon the way the individual patient presents the symptoms and how strong our suspicion is of serious problems. I've only dealt with one of the aspects of the evaluation for chest pain, but there are many, many other areas and presentations of heart disease which may be evaluated differently.
Right. The thing of it is Dr. Jordan Garrison has joined us. Dr. Garrison, before I go on, can you unmute yourself and introduce yourself, please?
Good afternoon. My name is Jordan Garrison. I am a general surgeon, board certified, and presently I am specializing in venous disorders and vascular problems. Thank you for having me here today.
All right, thank you, Doc. Dr. Badu, let's get back to you again. There's a question that came in about, and it's interesting. They says, which is worse on the kidneys, hypertension or diabetes? Because I have both.
That is a very good question, and that's a question that we see a lot in clinical practice. To be honest with you, both of them are equally bad. High blood pressure damages the kidney equally as much as diabetes. In the Western Hemisphere, diabetes and high blood pressure are 1 and 2 causes of kidney failure. So to ask me which one is worse, I have to say they're both equally worse.
Yeah, yeah. Now, at what stage, another question came in as what stage do you, or how do you know when someone needs a kidney transplant? How do you know that the kidney is not functioning at all or not enough for that particular person?
Okay, so to answer that question, I have to answer in two levels. The first level is that we have to determine that your kidney has what we call chronic kidney disease, that's chronically damaged. Now, when the kidney is chronically damaged, now we have to stage it. And the staging is based on the degree of function of the kidney. We have from stage 1 to stage 5. Now, in terms of the question that you're asking me, for transplant to be considered, usually is when patient's kidney function is at a stage 5, which basically means that the kidney is functioning less than 15%. So at that stage, when you be considered for kidney transplant.
Yeah, yeah. All righty. There was one that came in. Can you live your life long on one kidney? That was one question.
Yes,
yeah, go ahead.
Yes, you can. You could survive with one kidney. Although the one kidney working, doing the work of two, eventually gets, for lack of a better word, gets older quicker. But it could survive for many, many years on just one kidney.
Right, right. All righty. I'm going to ask some general questions now that are coming through.
Can I ask a question here?
Yeah, sure.
Dr. Badu, if you're saying that there's the one kidney, eventually fatigues, what do you tell somebody who is a potential donor of a kidney? How do you counsel them?
That's a good question. The counsel I would give them is that, they have to be fully aware of the potential of kidney disease eventually developing in themselves, but they have to start taking precautions, try to avoid any kind of insult or nephrotoxins agent, meaning like a lot of pain medicine that people take. They got to be aware of that. If they're the kind of person who participate in aggressive sports, they have to be aware of that, because they have to start limiting or decreasing their risk factors for developing chronic kidney disease in the future. Right. But that should not deter you from giving a kidney or donating a kidney. It just means that now you may have to adjust your lifestyle.
Yeah, I have a question, and what I would recommend from the whole panel, if you have a question or that you want to ask, or if, just chime in, definitely chime in, because we all have our different specialties, but they all affect the kidney. Dr. Salam and Dr. Badu, what about the psychological aspect of donating a kidney or receiving a kidney? And it must be, I can imagine it being very traumatic as far as the psychological or mental effects from that. Can you give us some understanding?
Well, typically, Dr. Salam here, typically when you're donating a kidney, there's a good chance you're donating it to someone that you love. So of course we prefer symmetry and body integrity, but if you're thinking that someone's life may hang in the balance, particularly a loved one, that makes it a much easier decision.
All right, Dr. Badu.
Can I ask a question, Omar? The question I have is twofold. At a time when, we talk about disparities in our community with respect to people who meet the criteria for a kidney, what's the process? What's the wait time? And is there that overlaying disparate attention to who gets a kidney and when? And then the second question is, in our community, there are many people who refrain from blood transfusion. And is there a correlation with respect to willingness to accept a transplanted organ in patient who is unwilling to accept blood? Is there a separation?
Yeah.
Okay, so let me answer the question in two phases. The first question is with what Dr. Obey asked in terms of the mental aspect of being a receiver or a donor. As Dr. Karim already stated, the person donating normally is coming from a positive viewpoint. They have a relative, a friend who is sick. So a lot of times it's a lot easier. They're more optimistic in giving the kidney. The mental adversity on that person is a lot less. The person who's receiving the kidney is usually the one who's going through more hardship, either because of the diagnosis of having chronic kidney disease, they've been on dialysis for many, many years, and all of a sudden then they receive a new leash on life. So they do tend to become more appreciative of life. They do have a new perspective on how to approach this. So I think in that aspect, on both parts, is a win-win situation for both people. You have one person who's truly altruistic and is giving, and the other person who's very thankful that somebody has given them a new leash on life. So the positive sides of the transplantation is all good from that standpoint. Now, in terms of Dr. Anderson, your question, in terms of what is the time frame on transplantation? Well, kidney organ transplantation normally is very, very difficult to come by because most people are not willing to donate a kidney. I'm sure most of us here, if we were to do a survey, none of us, or maybe very few of us, have signed their driver license to donate an organ. So it's very hard to come by, and especially in the African American community, either because of due to lack of trust from previous history of different things that has happened in the past. So most of us, so there's a lot of shortage of organ, especially when it comes to the African community. But with that being said, the criteria for donating or receiving an organ is based on different things. So I will first talk about donating an organ. If you want to donate an organ, you yourself have to be in good health. You should be free of chronic diseases like diabetes, or if you're on high blood pressure, you should not have more than one blood pressure medication controlling your illness. You also have to hopefully have no other chronic diseases that will predispose you to having kidney disease in the future. And of course, having an equitable or compatible blood type to the person that you want to give the blood type to. Now, in terms of the receiving person, there's multiple criteria for somebody to be qualified to receive transplant. One is, of course, showing that they require the transplantation, they meet the basic need, having chronic kidney disease and being on stage 5. But the most important thing also is their lifestyle. They have to show that they have compliance with their chronic disease medications. And that becomes very important because a lot of the immunosuppressive medicines that you have to take, maybe 10 pills, 5 pills, and you have to be taking them on a regular basis. So they need people who are very compliant with their care, people who are compliant with everything they're supposed to do. And that will indicate the kind of person or the kind of patient you're going to be if you're going to really take good care of the kidney that you receive. So that's one thing. And then the next thing, of course, is the psych portion. Is you have to have somebody who doesn't have an active psychosis or psych disorder, or where their psychiatric illness is not controlled. If they could have psychiatric illness, but if it's well controlled, then it's fine. But if it's not controlled, that may be an absolute contraindication because it may deem that the person may not be willing to take the immunosuppressive medications. In terms of the blood types, there's different blood types, as we may know. There's, the AB, or we have somebody who's an O, A, AB, or B type. So based on your blood type will determine what kind of organ you can receive. That's the first criteria. There's other antigen criteria, but the major criteria is having what we call compatible blood type. And I could go into that briefly if need be.
But, I think the question, as I heard, and I think that as you'd indicated before, both hypertension and diabetes are equally damaging to the kidney, and both of them are disproportional in terms of the impact on the African American community. The diabetes is probably the leading cause of renal failure, and that renal failure leads to dialysis. And so, as you indicated, the kidney is responsible for a lot of things. I look at it as being mostly responsible for balancing a lot of things. The body generates acid, and it sort of makes the base that sort of counters that. It also is responsible for balancing the amount of water. And as you indicated, when you eat protein, the breakdown product of protein is nitrogen, and the only way your body can get rid of nitrogen via the kidney. So the kidney is responsible for eliminating a lot of things. And if those things build up, you have excess water, you become edematous. That means you start to swell. If you have excess buildup of these protein, that BUN nitrogen, it gets high enough, it could damage lots of things, including your brain. And so a lot of individuals that end up with renal failure, either because of hypertension or because of diabetes, end up on dialysis. And once you end up on dialysis, you know, depending upon how much you accumulate these things, how often you need to get dialysis, there are two forms of dialysis, either peritoneal, where they use the lining of your abdominal cavity to sort of filter things out, or via the bloodstream. I'm not sure, and this is my opinion, that all the individuals that are on dialysis that could benefit from a renal transplant, where you no longer have to be hooked up to a machine, you no longer have to be dialyzed, are offered the option of getting on a transplant list. And so I think that if you look at the number of individuals who end up getting renal transplants that are on dialysis, my guess is it's disproportionate that Caucasians are more apt to get renal transplants than African Americans, because a lot of the African Americans don't really understand that that's a viable option. If you look at where the renal transplant centers are, and they pop up, they're all over the place, that are in African American communities, I don't see the number of individuals. I have an attorney friend who ended up having to go on dialysis, and I asked him, I said, did anyone talk to you about a transplant? He said, no. His wife is a judge, he's got the means, and it wasn't even raised. So I'm just not so sure that the conversation about the ability to get a transplant, because when you talk about immunosuppressive, that means your immune system has a tendency to recognize things that are not of yourself as foreign and tend to reject it. And so there's a conversation about your willingness to do that, but you actually don't have to do that until you actually have a transplant. And so I think that it's a broader question as to whether or not all the individuals that are on dialysis, even the subject of the possibility of a transplant is even raised or not.
Yeah, excellent, excellent.
Go ahead. I'm sorry, I have two renal related points to make. Number one, the kidney has myriad functions, one of which is to clear certain medications. There's certain medications, like the one that comes to mind is lithium, which is a primary mood stabilizer that's exclusively cleared by the kidney. So if someone has kidney difficulties, then lithium should not be your first consideration for a mood stabilizer. The other thing in terms of transplantation, just think of it in terms of fairness, justice, and maybe the golden rule. So I think someone mentioned that not many of us, I think it was Dr. Badu that mentioned that not many of us on this call have signed up to be organ donors, and that's delineated on your driver's license. Initially, I did not. I subsequently listed that I wish to be an organ donor. Let's talk about why I didn't. I think I saw in a movie once or I heard some urban legend that if you are listed as an organ donor on your license, then perhaps there'll be less of an investment in saving your life in the service of harvesting your organs so they could be available for others. But then I thought, wouldn't it be a shame if I had a life-threatening illness and I needed an organ, or if my child needed an organ? And what if everyone adopted the same position I had and said, no way? And then I said, you know what? If you're expecting to receive, then you should expect to give. And that's what motivated my decision to change the designation on my license to organ donor.
Excellent, excellent.
I just would like to say, I'm sure Omar can add to this. I did critical care pediatrics for 15 years, and very often in children, due to trauma, automobile accidents, you have to have that conversation with parents about their willingness to donate. There are a lot of individuals that are in need of different kinds of things, cornea, liver, kidney, there are lots of different things, even now islet cells with the pancreas. So it is a difficult conversation to have, but I think that there is probably as large a need in African Americans of organs than of other folks, and it's something to consider. I've been signed my willingness to donor for years ago. So it's something to think about.
Yeah.
Omar,
Julie,
The only other comment I want to make, Dr. Salam, is just because drugs are cleared by the kidney doesn't mean that you can't take them. You know, sometimes you take advantage of the fact that you may only need to take one dose as opposed to 3 doses a day because it takes longer to clear. So it is something that the physicians have to be aware of if indeed the drug is cleared by the kidney. You just may not need to take it as frequently if indeed your creatinine is elevated.
Okay, Dr. Garrison.
Weigh in on that a little bit.
Hold on, Dr. Garrison, and then Dr. Fredericks. Go ahead.
You know, Dr. Salam was talking about why. Let's ask the question why. In some communities, and I'm going to particularly talk about the Muslim community, that there are certain prohibits against certain things. Muslim community believes that organ donation shouldn't be, it's haram. It's something you shouldn't do. Because why? Because you may need your organs when you get to heaven. So there are a lot of religious organizations that have different views on organ transplantation and organ donation. Mm-hmm. The other one, you know, and I recently went to a conference in which we had to look at the ethics within the Muslim community. And do our ethics need to change according to what the science is right now? And that was one of the topics we talked about. We also talked about the psychological impact and people wanting to commit suicide and things like that in the Muslim community. It's like you'll go to hell if you commit suicide. So there need to be some interventions that come along with that. So I think that part of the outreach needs to be to these ecumenical associations and try to get the ecumenical morals changed and in step with what the current thinking is.
Okay.
Dr. Garrison,
Hold on.
I got you going now.
I just want to tell one little story. You know, I said I did critical care pediatrics, and we had a number of individuals that need liver transplants. Mm-hmm. The leading place of liver transplants was in Pittsburgh. They had a special ward for Saudi Arabians to come in to get liver transplants. It may depend upon the wealth of the Islamic individual as to whether or not they're willing to get transplants or not.
All right. Dr. Fredericks, thank you.
It's not that deep. It's just that a lot of times you get patients, African-American patients who come in when you're talking about BUN and creatinine, and their BUN and creatinine tends to be higher. Is there a reason why that tends to happen?
Dr. Badu?
Can you repeat that question?
Can repeat it, please.
The BUN and creatinine being higher in African Americans than Caucasians.
The BUN don't tend to be higher in African American, but the creatinine tends to be higher. And the philosophy is that it's due to muscle mass. The belief is that sometimes African American may have more muscle mass, and creatinine is in a sense a byproduct of muscle mass. Mm-hmm. So where you have more muscle mass, your creatinine may be slightly elevated. So it behooves the physician when you're evaluating a patient who may have a creatinine slight elevation, not necessarily to mean that they have kidney problems, but to closely look at the total picture of the patient and make a decision based on that.
Right. Mm-hmm. I just want to bounce back. Dr. Garrison made a point. Dr. Sprock made a point about the ICU and talking to family members about donors donating organs. I truly think that the relation that physician has with that family means so much. You're talking about something that's very personal, something that's heart-wrenching, something that's possibly a lifesaver. And I truly think that the connection that you as the physician has with that patient or that family means so much as far as they're feeling that they're doing the right thing, or they can, should say, not that they're doing the right thing, that they can make a honest decision. And I found that in the past, that especially when you're talking about African Americans, when someone can identify with the physician that they're talking to, meaning either race or the amount of time that they've known the physician or that they're their private physician, it really means a lot. maybe Dr. Salam could add a little bit more as far as that's concerned, since we're talking about a lot about organs and donating.
Well, of course. I mean, in almost every discipline of medicine, a lot of what we do has to do with rapport and the relationship, and that is a function of trust that you have with the person that you're serving or the community that you're serving, and that even affects the quality of information that is given to you when you take a history. So, of course, we know that we're representatives of an institutional bureaucracy called organized medicine that has a checkered history in terms of how it's interacted with communities of color. But again, just to keep things simple, I think in terms of fairness and justice, because none of us could predict if and when we will be in need of a vital organ. It's funny, the comments that people make when their lives are flashing in front of them. For example, in the setting of COVID, you're hearing about people on their deathbed saying, I wish I would have worn the mask, or people who are in desperate need of an organ realizing that perhaps I should have been more generous and altruistic, or now I understand how it feels. But while I have the floor, I have to mention what Dr. Garrison stated. I've been a Muslim my entire life, and I'm unaware of that, and therefore I have to research it in terms of organs being needed in paradise. I don't want to turn this into a theological discussion, but my understanding is that the body is a time-limited vessel that has an expiration date, and that it's the soul that's actually the priority. So if there's anything that would affect the Muslim community in terms of serving as organ donors, in Al-Islam, we believe you have to get the deceased in the ground in about 48 hours. And so Dr. Sprott mentioned you had to have these very difficult conversations in terms of organ donation. They're conversations that have to be done with ruthless efficiency because the organs have an expiration date. So it's important to have these conversations, and as it applies to the Muslim community, I think it's getting them into the ground, within a prescribed period. But I'll research that question, and if I come up with anything,
I don't think you're going to find it in a book. I think you're going to find it on the street corner in downtown Newark. Okay, that's where that comes from.
And so here, and the question is, where is it written? That's what I would ask these folks. Yeah. Where is it written? Where's your evidence? And if you can't produce that, then perhaps like those same folks on the corner saying, perhaps they're just freestyling.
Yeah.
All righty. You know what we're going to do just for a minute? We've got a lot of questions coming in. So let me get some of the questions that are coming in if possible. All righty. Dr. Atherley, would you be able to comment on whether the daily dose of aspirin can decrease the likelihood of a heart attack? This was part of that first question, Dr. Atherley, and I don't think we answered that aspect of it. There were a lot of aspects of the question, but this is what he wanted answered.
I didn't want to have the floor for the entire session.
I know. We'll keep it short. We'll keep it short.
I will now talk about some of the therapeutic aspects from the heart viewpoint. Now, the question of aspirin has been, of course, it has been controversial. I think now it is less controversial because since the 2019 publication of the effects of aspirin in terms of prevention of heart attacks has made it rather clear that it is not to be used in such manner, except for special circumstances. In general, in medicine, we think of primary and secondary prevention. Primary prevention being preventing the disease process where it's not yet been demonstrated. Secondary would be in patients who have had, for example, a heart attack, and whether or not an aspirin will help prevent them from having a second heart attack. As you all know, of course, the most significant risk factor for having a heart attack is having had one already. So if you've had a heart attack, you are at great risk for having a second one. Now, the role of aspirin is to prevent clumping of certain components of the bloodstream called platelets. Clumping of these platelets can help give rise to blockage of the arteries to the heart. And these blockages can lead to a diminution of the supply of blood to those parts of the heart, and hence heart attacks. So it was long felt that if we can keep the blood flowing smoothly and keep it thinned and not have these clumping forms, then we can help prevent heart attacks. And in fact, there have been long-term studies many years ago which showed, for example, the British nurses study showed that giving people aspirin and aspirin a day from age 40 and on helped apparently to prevent the occurrence of heart attacks. Well, we now are able to dispute that. And we say that as a primary preventer in one who has not had a heart attack or stroke or significant vascular disease of the blood vessels, there's no indication that the benefit that you may derive from taking an aspirin a day will have a significant effect on preventing your having, a heart attack or strokes, greater than the ill that you may suffer as a consequence of taking the aspirin. And of course, we're thinking about bleeding into the stomach and the gastrointestinal stomach system. So in terms of preventing primarily, the indication is no, you do not need to take an aspirin a day to prevent these if you do not have a very high tendency or likelihood of having a heart attack, multiple risk factors or previous heart attack. Now, the further component of this, however, is what about secondary prevention? Suppose you've already had a heart attack or had a stent placed in the heart, that's a little device to keep the arteries open, etc. In those situations, there's no question about, yes, take it. It is helpful in preventing, secondary prevention, of course, in preventing recurrence of any of these episodes in patients who've had heart attacks, interventions such as putting stents in the artery, heart surgery, etc. The one other aspect I may mention is the acute use, not just the chronic long-term use, but the acute use, although this was not specifically asked. If you think that you're having a heart attack, a part of the process of having a heart attack involves the clumping of these little platelets, these little components of the blood, clumping and blocking the arteries. And if you have a medication readily available, which can help to diminish the clumping of these arteries and hence diminish the furtherance of that heart attack, then do it. And that, of course, is aspirin. And to get you to act quickly, chew an aspirin. So if you think you are in the process of having a heart attack, chew an aspirin and get help as soon as you can.
Dr. Atherley, wasn't there a difference between males and females in terms of primary prevention and the use of aspirin?
There may be some slight difference in terms of the efficacy, but the problem is that this may be outweighed by the potential ills or side effects. And therefore, in the long term, it still is not clear that one should use it with the prevention primarily in those who do not have multiplicity of risk factors or previous disease.
But most patients that you and I see have high blood pressure and diabetes, and are probably maybe half of them are smokers. What do you recommend in such a case?
Yes, where there's a multiplicity of factors, a high likelihood that you can have it, then it may be much more reasonable than just taking it routinely. Some of the earlier studies were just routinely given to patients, but I think there may be some benefit, not just in the routine patient. A patient has multiple risk factors, and for those in our audience who may not be aware of the risk factors start primarily with age, more than 55 in males, more than 65 in females, males more frequently than females, high cholesterol, that's the bad cholesterol, the LDL, diabetes, high blood pressure, being overweight, sedentary lifestyles, the hypertension, these are some of the risk factors, and a multiplicity of risk factors can significantly increase your chances of having a heart attack or a stroke. So yes, where there's a very high tendency to have one, if you've not had one yet, then we can consider it more reasonable. But this may not apply to the average member of the population. But it's a good point, where there's a significant increase in the potential for heart attacks or strokes, then yes.
Okay, all right, there's some more questions. All right, Dr. Salam, there's a stigma in the Black community concerning organ donation. I love to loved ones or not. What can we as a community do to break the stigma as it is psychologically related?
Sure. I think, well, let me just clarify. As a child and adolescent psychiatrist, this is an issue that I'm dealing with too frequently because I have the benefit of a patient population with very young and healthy organs. But I think it starts with education and awareness and just having a conversation with members of the community and sometimes using intermediaries like members of the church or other trusted pillars of the community to expand awareness on this particular issue. Because as I mentioned earlier, this could be one of us or our loved ones who's in desperate need of a healthy organ. And you certainly don't want lack of information and awareness to interfere with someone's decision to donate an organ.
Mhm. Mhm. There was another question. Let me just move along. Thank you, Dr. Salam. I have heard that it may be easier for people living in other states than New Jersey to find and receive an organ transplant. Example, a person I know who needed a new kidney was advised to move to Florida because it would be easier to move up on the list. And easier to move up on the list there than in New Jersey. Can we comment on that, Dr. Badil?
Yeah, the availability of organ transplantation unfortunately relies on people donating or giving their organs. The areas that tend to have a higher donation rate, unfortunately, tends to be the area where there's a high crime rate. So places like Philly, DC, those, or even New York City, where those places have a higher crime rate, there's tend to be more availability of organs. In Florida per se, because of an older generation of people who may be older, and of course, because of that, they die sooner, there's also availability of organs. So the availability of organs makes your chance of getting the organs a lot easier based on where these people live and based on the death rate. But since we're on this question of transplantation, if I may take the opportunity to comment on some things that were mentioned before. Dr. Sprout had mentioned a colleague or a friend who was never told about organ transplantation availability. And that is a shame, but I have to tell you that in the kidney world and the nephrology world, there's multiple setup to allow the physician to talk to the patient about it. When we see patients in office at the earliest stages of their CKD, we are able to avail to them the different options, whether to go on hemodialysis or peritoneal dialysis, or even to transplantation. So this kind of conversation is able to be had. On top of that, if that opportunity was missed and the patient gets to the dialysis unit, we have in place social workers and nurses and nurse managers who will approach the patient on the first week or first month of starting dialysis and discuss with them the option of organ transplantation. Unfortunately, in our community, which we've kind of mentioned, most people are kind of weary about getting an organ transplantation, so they tend to refuse it. So it behooves both not just the nephrologist, but also the primary care doctor who's taking care of this patient to also push and educate the patient on the benefit, because as our studies have shown, when you are on dialysis, the average lifespan is about 5 to 10 years. When you get a transplantation, the organ transplantation, you're able to live to 20, even some people 30 years. So it's beneficial for people to try and get the organs, and it needs to be attacked on both sides, both by the primary care physician and the nephrologist.
Mm-hmm. All right, thank you.
Just a question, Dr. Badu, how many people of color nephrologists are there in the state?
That is very difficult. At one point, when I started practice about 2003, 2004, I think we had about 4 people in the whole state of New Jersey. I think right now they may be close to 10, but less than that. So there is very few.
And so my question is whether or not the number of African Americans that might be in need of possible transplants, whether or not the same discussion occurs when they have a non-African American physician or not. I think you talked about all these opportunities that may exist, but I don't know whether or not, there are lots of studies that show inherent bias against African Americans and all sorts of things in terms of offering of pain relief. You can almost name it. And I almost can guarantee you that the same thing holds in terms of those kind of conversations relative to African Americans who may be in need of transplants.
And I'm not going to disagree with you. I think you're correct. Unfortunately, the world that we live in, there is a lot of bias. There is a lot of racism, and people's racial bias or philosophy sometimes translates into the type of medicine that they practice. But that's why this kind of program is very essential, to allow us to go into the community and educate our people so that they can go back to their primary care physicians and talk to them and ask questions.
Mm-hmm. Excellent.
One other thing about the transplants. Motorcycle accidents are a very common accident that results in organ transplants. And Florida is kind of notorious for motorcycle accidents.
Yeah, Dr. Lee, please.
Oh yeah, so for Dr. Badu, I'm an orthopedic surgeon. We are colleagues. When I have a patient with end-stage renal disease that is a candidate for knee replacement or hip replacement surgery, it's a difficult discussion to have because you mentioned it. If they're on dialysis, their lifespan is shorter. They tend to have many other comorbidities, high blood pressure, diabetes. And in the orthopedic world, their failure rate from a joint replacement is higher than routine arthritis. So oftentimes I struggle with having that conversation. Is it really worth it to go through a big surgery? How much length will you get from this replacement, and is it worth it? And oftentimes patients do well for about 2-3 years, and then they just drop off. Whether it's because of renal failure, they get older and their morbidity goes up, and they tend to die. Do you have any counseling for me, or what I could tell patients about their candidacy for joint replacement when they have end-stage renal disease?
Excellent.
That's a good question. Unfortunately, I don't, to be honest with you, because it is a tough discussion. It is a tough question, because you're basically telling somebody that, it essentially boils down to the quality of life. When somebody has joint pain, knee pain, back pain, whatever it is, they don't want to hear anything. All they want to hear is relief. What can you do for me? Most people don't like, as much as we talk about it, most people don't like to be on chronic pain medication. So they want some kind of relief. But as you clearly stated, doing that kind of surgery also has its issues, and I think it's a discussion that needs to be done on a one-to-one, case by case, and based on a person, you could evaluate it a lot better.
Dr. Badu, what about demineralization of the bones with dialysis and chronic kidney disease? If supplements are given, does it help? And that may help Dr. Lee as well.
It does, but it depends on what stage. Renal osteodystrophy is a disease that we don't see as much now, but we tend to see it a lot because of different medication that is around. The medicines have gotten better, but it's still something that we see because sometimes patients' non-compliance with medications does happen. So in essence, with renal osteodystrophy, it's whereby the kidney gets, for lack of a better word, gets softer and weaker over time. So you're more likely to break, they're more brittle. So they're more likely to break. So if you do have a patient who has been non-compliant or has been on end-stage renal for many, many years, the chances of them having a brittle bone is a lot higher. So there's a much more of a higher complications with dealing with orthopedic surgery in general.
Excellent. I see that Dr. Graves has joined us, and we will be with you in a few moments, Dr. Graves. Dr. Salam, go ahead.
Yes, to speak to some of the issues of stigma and trust and adherence to physicians' recommendations, there was some really groundbreaking work done in the San Francisco Bay Area, in Oakland specifically, about Black men's adherence to medical recommendations when those recommendations came from a Black male physician. And I think in the study, they had Black male primary care providers, and they had non-Black primary care providers, and the patient's adherence to screening recommendations increased when they came from the African-American providers. So I say that to say that we should not discount the service we're providing here in terms of expanding awareness to the community and educating the community about these various medical topics, because more folks may be inclined to listen to what we have to say versus a collection of other physicians. And I know there was an opinion piece in JAMA where it referred to the Black male physician as the medical unicorn. And that speaks to pipeline and workforce issues that I actually hear Caucasian colleagues talking about this now. How can we get more Black male physicians? Because they realize this is a need. Everyone realizes this is a need.
Yeah, I'm going to digress here just for a minute. I've been asked and emailed several times as to why this panel is all African-American males. And the number one reason The number one reason is that we need more Black physicians, number one, but number two, we need more Black male physicians. And we're here to show our young men that they can be physicians too. So I'm just answering that question because that question's been directed to me many, many times, and I try to answer it each time it's directed.
Omar, if I may just say something real quick with respect to this, we should not discount the impact that our presence have. Currently, there are 2 students, undergrad, that I'm actually mentoring. One is in the application process now, and it came about because somehow they saw us on Facebook, and one of them reached out to me. And the next thing you know, I'm writing, having them doing what we call, observership with me and applying and counseling them as to the importance of grades and so on and so forth. So, Dr. Salam, you really push a button that speaks to the importance of our presence.
Also, Omar.
Yes.
In my 37 years or so, I've also had at least 4 young people who went into the medical field. One of them through just with the discussions that we had in the office, and they went on to be a great doctor.
Right. Yeah, I think, and that's one of the reasons that, I'm so passionate about this, all of us and what we're doing is because I've had several students starting at high school and going through, and even the 3 docs who we all know that formed a pack in New Jersey and Newark and got through Seton Hall. I was the chairman of the board of their program at Seton Hall and helped get them through. And that's just so important. And I'm so proud of all 3 of those brothers on how they're doing and what they're doing out there in the community. And they're actually reaching back to young people and letting them know that, they could be physicians. We're so proud of them. So, all right, not to get off track, here we go. And I will bring, we'll get one more question and then I'll bring Dr. Graves on. This one, I have been twice denied to sign up for to be a match online. I believe because of my BMI. Obviously, I don't know if it's because he's too heavy or too small. I'm not sure. I'm assuming that he's overweight. I understand the denial, but I am also frustrated by the decision because of the need for African American donations. Is there anything I can do to donate if the doctor deems me healthy enough to do so? So number one, Dr. Badu, is there a weight limit on this? And Dr. Fredericks, as far as reducing weight, maybe you can chime in on that as well. Dr. Badu.
In terms of transplantation, to be a candidate to receive or to donate, you have to be below a certain BMI. And if my memory serves me correct, you have to be below 35. So based on that, if your BMI is higher than that, you will not be considered a candidate until you lose some weight. And I think most of it has to do with the worry about the complication of the surgery, healing properly, the incision. So they need it to be, because for them to have to, and our bariatric surgeon could talk more about it, but I think it has a lot to do with the complications of the surgery. So you have to be below 35 to be considered.
Okay. Dr. Fredericks.
For BMI, it's very tricky, right? Because some of us feel that BMI aren't well appropriate, but BMI actually gives us an idea of how heavy a person is. If you have a BMI where we take your height and your weight and we put it in the calculation, and we get a particular type of number, we get a sense of how heavy you are. If you have a BMI that's greater than 35, that starts to become problematic because that's when you start to have health-related issues. And if your BMI is 35 and you have health-related issues, you're a candidate for weight loss surgery. Or if your BMI is greater than 40 and you don't have health-related issues, because you're so heavy, like the doctor alluded to, it becomes more problematic for you, and that qualifies you for weight loss surgery. And weight loss surgery, it helps to get that weight down, because once you get heavier and heavier, It's so hard for the body to actually lose that weight. As Dr. Bain will mention or talks about, having such a high BMI takes a lot for you to get it down. It takes a lot of changing your diet. It takes a lot of exercise. It takes a process to get that weight down. And the body fights you to keep that weight up, because weight is how the body gets its energy source. So when your weight starts to go down, the body fights you to get it right back up. And so one of the ways to get it to come really down is actually weight loss surgery. Weight loss surgery is one of the main ways to get that BMI down to an acceptable weight. And when your BMI comes down, your health starts to get better. Just losing 10% of that weight gets rid of some of the comorbid conditions. And so that's why I tend to do weight loss surgery with patients who have significant comorbid conditions, because that's one way to getting them healthy and getting them a better lifestyle.
Okay. All right. Thank you. It's halftime for us, and I'm so glad that Dr. Graves has come. He's still his. Let me see if we can get him up here. His video hasn't come up, but what we'll do is let me do my halftime spiel for those who missed and what we say in the beginning. Number one, please do not change any aspect of your medical care before you consult your physician. We are docs here ready to answer any medical question, but it is medical information and for your knowledge so that you can improve your health. We're not here to change what your doctor has prescribed for you, because only your doctor knows your medical problems and how to best take care of you. So do not change any aspect of your medical care until you consult with your physician. Also, understand that we're going to introduce each other. Well, we're going to introduce ourselves, I should say that. But first, I would like to start with Dr. Wayne Graves. I would like for him to introduce himself. I am so pleased to have him here. And let me set the stage. Dr. Graves is a physician that has direct contact and information and understanding of COVID, as well as some of the vaccines and some of the medications that we try to treat this disease with. We need to understand these things so that we can properly make decisions as to how to proceed with our lives going forward. It's a major problem in the African-American community. I'm a critical care ICU doctor, and I see the sickest patients in the hospital, and it's overwhelming to understand how many people are expiring or dying because of this disease. So to have knowledge, to have understanding is the greatest thing that we can have. Dr. Graves, thank you for coming on. And this was a last minute change. He volunteered to come on at the last minute. I'm so happy that you did. Could you introduce yourself to us? And then the rest of the doctors will introduce themselves and we'll get going, okay?
Yeah. So I'm trained in internal medicine and infectious disease. That's my specialty. I spent 3.5 years working at the Centers for Disease Control in Atlanta, Georgia, before I came to Harvard University, where I was the head of the infectious disease group and the HIV clinical trial group. Now I'm in pharmaceutical research, and still keeping my nose into medicine. So I'm glad to be able to participate with you folks.
All right, thank you. Thank you very much. We're going to start with Dr. Garrison. Everybody unmute themselves. Dr. Garrison, can you tell us who you are? And we're going to go through one more time so people who didn't start off with us will know each physician and their specialty.
My name is Jordan Garrison. I'm a board certified general surgeon, bariatric surgeon, vascular surgeon. I am presently working in a facility in which we deal with venous disorders. Dr. Graves, I'm so glad you're here. I have a very pertinent and important question, which is of a timely nature, that I need to ask you once we finish these introductions. Thank you so much, guys.
All right, Dr. Court, please. Can you unmute yourself, Dr. Court?
I'm Dr. James Court. My specialty is internal medicine. I have a practice in East Orange, New Jersey. I treat adults, no children, no surgeries.
All right, thank you. Dr. Atherley.
My name is Trevor Allen. I'm a board certified cardiologist. I specialize in interventional cardiology. I practice predominantly at Newark Beth Israel Medical Center. And one of my key interests is, of course, is the teaching and training of medical students, residents, and cardiology fellows.
All right, Dr. Sprott, thank you.
Yeah, I'm Kenny Sprott. I'm a pediatrician. My background is in general pediatrics and pediatric critical care, and I was the acting chair of pediatrics at New Jersey Medical School for 9 years.
All righty, Dr. James Lee.
James Lee Jr., board certified orthopedic surgeon with a subspecialty in sports medicine, currently serve as team physician for Bloomfield College. Practice is in Essex County.
All righty, and Dr. Badu, our special guest.
I'm Dr. Andrew Badu. I'm a nephrologist in Essex County. Thank you.
All right, thank you. Dr. Salam.
I'm Dr. Kareem Salam. I'm a board certified adult and child and adolescent psychiatrist, and I'm the medical director of an adolescent unit in Philadelphia and a founding member of Global Health Psychiatry. We publish mental health literature to attack stigma as it applies to mental health in the African-American community.
Mm-hmm. Dr. Anderson.
Yes, I'm Patrick Anderson. I'm a board certified gynecologic oncologist, meaning I take care of women with cancer. Chief of GYN oncology at Newark Beth Israel, where Dr. Atherley and so many of this other gentlemen work.
All right. Dr. Garrison, please.
No,
I did you right there.
Yeah.
I think you changed on the screen here. I'm sorry about that. Dr. Fredericks.
I'm Dwayne Fredericks. I'm a weight management specialist. I do both surgical intervention as well as non-surgical intervention, and my office is in South Orange.
All right, excellent. And I'm Dr. Omar Bey. I'm a pulmonary critical care physician with a subspecialty in nutrition. I'm the director of nutritional support for the ICU at a major hospital in this area. All right, thank you very much. All righty, Dr. Garrison, you said you had a question. Let's get that question going.
Right. I'm not going to say I'm more on the front line than anybody else in this meeting. Everybody's on the front line as physicians. And my hospital has said that they did a survey and said that 70% of the respondents within the medical hospital said they would take the vaccine, 30% said they wouldn't. I have colleagues saying they won't. And the hospital is gearing us up in order to schedule us for vaccines. What are your thoughts? What are your recommendations?
You have to
unmute yourself.
Still muted.
Asked to be unmuted.
Yeah, okay, sorry.
Right, there we go.
So I think it becomes a risk-benefit situation, but in the context of a hospital setting or a healthcare setting, I think the employer is going to want to have as many people vaccinated as possible. And we know from influenza that becomes very important. If you talk to legal people, from what I've been hearing and from what I've been reading, an employer actually can require that you be vaccinated. You have the choice to leave or not leave. There are some very special exceptions for religious reasons and for some very specific medical conditions. But in general, as I understand it, an employee can be required by an employer to get the vaccine. Now, I think you're asking a slightly different question, a more general question. Would I get it if I were in a hospital setting in your situation? And my answer would be, if it were a few months ago, I would have said probably not, I'd want to wait. But I'm a lot more comfortable now, given the fact that towards the end of the vaccine trials, at least before the application to the FDA, a number of the manufacturers came together specifically because of the pressure that was being mounted by the government. These manufacturers came together and decided, look, we are not even going to file for emergency use authorization until we have satisfied what are considered the essential safety criteria as mandated by our independent data monitoring committees. That was one thing. The second thing that happened is that FDA got together recognizing that there was all this concern and pushback and told the manufacturers, in any case, look, We won't even look at your emergency use authorization application unless you follow patients who've been vaccinated for at least 2 months after the last dose. Furthermore, we want to see the data on at least 50% of all the people in your study who have reached that time point. So with that kind of level of oversight and with that amount of data, and now having the FDA advisory panel, which is an outside independent group. These are not government workers, or these are not manufacturer people. These are independent experts in the field, typically from universities, and there's usually an ethicist, a lawyer, and so on. And they voted to approve or recommend approval for emergency use authorization. So I'm a lot more comfortable, and also seeing that the UK regulatory body also recommend that we use. I'm pretty comfortable now saying that I would take the vaccine and would recommend that you consider it as well, unless you've got some very specific reasons not to consider it. I will tell you one thing though, at the advisory committee, there were 11 people who voted in favor, 4 people who voted against, and 1 abstention. The 4 people who voted against it didn't vote against approval because of any safety issue or efficacy issue. They were concerned because in the studies, the Pfizer study in particular, they really looked at individuals from 16 years and up. And they would have been comfortable if it was approved for adults 18 and up, because the number of individuals between the ages of 16 and 18 was relatively small. That was their only concern. So I feel pretty comfortable with this vaccine.
Mm-hmm.
That was a long answer, I know.
Yeah,
It's the one we needed.
I wanted to give you some background to the whole thing.
okay.
Jordan, just, a comment, almost all of the vaccines that are developed are not tested on children. And in general, they wait until there's a large number of adults that have had it, and then they start to weigh in lower. And again, if you look at the number of individuals involved in the clinical trials, it's a drop in the bucket in terms of the number of individuals that will be receiving it within the next couple of months. So you're talking about millions of folks that are going to be getting the vaccine within the next couple of months. And if you start to think about it, if an adverse event occurs, 1 in 100,000, okay, and you have 20 million folks that are going to be getting it within the next several months, there are going to be a number of adverse reactions that may crop up. And so I think that as you start to look at the number of vaccines that get administered, you'll start to see the possible adverse effects that might come up given those numbers. So I think it's important for folks to be aware. But again, we're of a certain age where many of us have the risk factor related to age and the risk factor related to maybe underlying conditions. And so, there are, 3,000 folks dying a day, and it's all over the country. And so I think, when you talk about risk benefit, just about everyone I know now has known folks who have relatives that have died. I think it's serious enough for you to consider, do you want to take the risk of getting it and possibly dying, as opposed to getting it and maybe have, some minor kind of illness. But I think the for me, when the hospital gets the first dose in a couple of weeks, as the CEO of my institution, I'm going to put my arm out there to get it.
I'm with you. I'll be the first one in line.
I just add one more thing to give you some perspective. You're absolutely right, Dr. Sprott. We are going to see adverse events. It will happen. Nothing is foolproof in medicine, as you know. And as we go to millions, what we know from the first few cases in the UK, there are 2 anaphylactic reactions that occurred.
Mm-hmm.
So, as a result, now we're not going to recommend that this vaccine be given to people who've had any severe history of allergy. These 2 individuals were people who had severe allergies. They were even walking with the EpiPens. So, so those people shouldn't get the vaccine.
Mm-hmm.
Why didn't that come up in the Pfizer trial? Well, they excluded individuals with severe allergies. So it's not surprising that they'll just had 0.6% cases of allergic reactions in the placebo group and 0.5 in the control group. So, you know, these things are going to happen. But what we do know from other vaccine development programs is that most of the important adverse effects tend to occur within the first 60 days. There will be other rare events that occur after millions of doses of vaccines, not even thousands. So we can't wait until that long to be able to pick up the rare adverse events that will undoubtedly occur. So that's the perspective we have to look at this vaccination effort and program. And I think that, you know, as physicians, as responsible physicians, because there are some that are in another world, I think we need to be able to explain and give our patients the pros and cons, but we don't want to be too skeptical either, because we're already facing a problem in our communities, as you probably know. You know, if you look at different surveys, there are different numbers of people who are willing to be vaccinated right now. But in general, for Black community, we are less ready and less willing to accept the vaccine. And for some valid reasons in some cases, you know, the history of big pharma, the history of government treating Black folks, the Tuskegee whole experiment, those are things that are difficult legacies to live down, forget. So we have our job cut out for us in being able to, you know, encourage people to be vaccinated, given the fact that it's really decimating many in our community.
Dr. Graves and Dr. Spratt, maybe you can help me with this. It's a different narrative when we speak among ourselves, because we understand science and we understand statistics. I spent this week talking to folks about my understanding of the history of vaccines, going from actually using parts of live pathogens to attenuated portions of pathogens to segments of just molecules, parts of pathogens, which is where we are now. Because one of the concerns I find most people have is twofold. One, their thought is embedded in the history. And I have to convince folks that those experiences, at best, was unethical. Yeah. Now, for reasonable, essentially foolproof research to come to the forefront, there has to be an ethical aspects of it. And I spend time talking to people about the makeup of an IRB and explain to them what IRB is and how research gets to where it is today. But the concern most people have is the speed at which this vaccine came about. And what I find myself doing, and I'm not sure that I'm completely correct, and this is where I'm leaning on you guys, that the actual platform for developing the vaccines today, and specifically the coronavirus vaccines by multiple companies, those platforms already existed. So we just had to introduce pieces into the puzzle and get the reaction going again to get to this endpoint. So Dr. Graves, if you may just comment on that aspect of it to try and convince folks that actually the alacrity to which we're seeing the product, really most of the basic work was already historic.
Right, so there are several ways I'll answer you. There are different platforms, as you alluded to, in terms of developing a vaccine. Some vaccines are made using attenuated virus, killed virus. But the neat thing about the Pfizer BioNTech vaccine and the Moderna are that these are two new platforms using messenger RNA. We've never had messenger RNA vaccines before. There are some pluses. We can make the vaccine a lot faster because we don't need to grow viruses and attenuate them, all the stuff that we need for the other vaccines. So the speed is already compressed. The second benefit we've had is that with the previous SARS outbreaks, the initial outbreak, 2002, 2003, and then the MERS outbreak, 2012, people began to develop these vaccines. And in fact, one would have been tested if the epidemic hadn't died down. So we aren't starting from scratch with these vaccines. And the whole method of producing the vaccines allows for a quicker process. The third point I would make is that the reason that we were able to go faster is that rather than what we typically do in clinical research, where we do a phase 1 study where you check for safety, then you do small numbers, then you go to phase 2 where you have a slightly larger number where you're looking at safety and limited efficacy, and then to phase 3 studies. These were almost being done, not quite in parallel, but almost, so that there was compression of that time between as well. And then finally, we can't avoid saying this, but there was tremendous amounts of money put into developing these vaccines. So you're talking tons of money and people. And because it was such a national, in fact, international problem, I mean, scientists were really cooperating well, working together. This is unprecedented. I mean, I think from a scientific standpoint, this is amazing achievement. I can appreciate that the person who isn't familiar won't understand. And I think you're doing absolutely the right thing by pointing out the different steps that you've made.
You know, Patrick, I like to, it's not the same thing, but I like to say, each year when we have an influenza vaccine, it's a new vaccine. And it's predicated on a belief about what the scientists believe will be the few types of influenza that are going to be most prevalent in the next flu season. And so they make that decision, and then they start to work on developing the vaccine. And every year, it's a different vaccine. It might be that there's a single component that's a carryover because of the fact that it wasn't as great as it was last year. But the 3 types of viral influenza that are administered each year, it's a new vaccine. And so it's not as if they had to, come up with a different platform. And again, he talked about this messenger or RNA. But the fact of the matter is that this virus wasn't even known until sometimes at the end of last year. And so, as he said, a tremendous amount of money was thrown at the pharmaceutical companies, and they started to work 24 hours a day, 7 days a week, trying to come up with a viral vaccine against this specific type of coronavirus. And indeed, when you talk about, the entire virus, which is, again, you could talk about attenuating, which makes it less kind of likely to cause disease. And then there are some diseases, but for the most part, we're not looking at many of those attenuated viral vaccines as new vaccines. Some of the old vaccines are still live attenuated viruses, and people that have weak immune systems aren't given those kind of live attenuated viral vaccines. Now we're looking at the way that the virus can enter into a cell and take over the replication and just target specific components of the virus. So you're not talking about giving something that is going to go into a cell and replicate or reproduce itself and cause disease. So you're talking about giving something that will be a specific component that your immune system will recognize, and then when the virus comes along, attack that specific part and take it out. And there's some, question as to whether or not it actually prevents disease or prevents replication. There's some question about that now. But I think the fact of the matter is that they've done, an outstanding job in terms of getting multiple pharmaceutical companies to come up with multiple vaccines, not all of which are the same.
I have a question. Can you truly explain, Dr. Graves, how this vaccine works? You understand what I mean? There are, like the flu vaccine, you give it and your body prepares itself to attack any flu, organism that comes in, of that strain that comes into your body. How does this vaccine work? Because what they're talking about is there's a possibility that even though the vaccine may decrease the symptoms that particular patient may be having so that they don't die from COVID, they may still be a carrier in spreading the COVID virus to others. Can you address that at all?
Yeah, so there are still some things we don't know about the vaccine, of course. But basically the vaccine works, at least the messenger RNA vaccines. The messenger RNA carries the instructions for the cells to make the spike protein. The spike protein then triggers the immune cells in our body to produce antibodies to the spike protein. Mm-hmm. So what we're doing is fooling the body to make antibodies to that very spike protein on not the actual virus, but in anticipation of being exposed to the real virus with the spike protein, the antibodies are already there. The question comes up, well, there are several questions. We don't know how long this immunity is going to last, even from the vaccine. We know that in adults who have the natural infection, antibodies hang around for at least 6 months in most people, maybe less than some. But we don't know if that's the whole story, because your immune response to a pathogen depends not only on your B cells and your antibodies that you produce, but also your T cells. And because we have memory T cells, you know, they may be very efficient in helping us respond. But having said that, we do know that there are a few cases where reinfection has occurred. There's no doubt.
Well, Dr.
But it's
Graves,
very, very limited. Sorry?
Dr. Graves, if you were exposed and you have antibody already positive, should you take this new vaccine?
Well, let me come with that in a little bit. That's a good question too, but let me just finish Dr. Bay's question. So what we're doing is basically fooling the body to be prepared for something. What we don't know from the vaccine is how long immunity will last. We don't even know for sure in a natural infection. So because the vaccine is still new, we have to follow these individuals, and they're going to be followed for at least 2 years. We will be able to say, do we need to give another vaccine like we do with influenza every year, every 6 months, every 2 years? We don't know yet. So that's a little premature. Your question, though, is very important. The AstraZeneca trial, that vaccine is not yet approved. It's going to be interesting because whereas the Moderna trials and the Pfizer trials only looked at the severity of disease, moderate severe disease, they didn't look to see whether or not people who received the vaccine were not able to transmit the virus. In other words, you might prevent infection, but are you really interrupting transmission? And there's precedent for this because when you use inactivated apple, you prevent severe disease, but you don't prevent necessarily transmission to another person. So we don't know whether or not the vaccine will interrupt transmission. Yeah. In addition to preventing severe disease. We have to rely on the AstraZeneca trials, or now that they're modifying some of the trials that are ongoing, we'll be able to answer that question better. So that's the most I can say at the moment.
And what you mean by transmission is?
Asymptomatic.
Right, yeah, that you.
In other words, the vaccine may prevent severe disease, but you might still be infected.
Right.
And we know that 50 to 60% of individuals who are asymptomatic even right now with a normal virus can still transmit infection. So that's what I mean.
Just you know, another point is that, you know, when you get exposed to the actual virus, it takes a while for you to test positive. And in many circumstances, you are spreading it before you actually become positive. And then you become positive. Now, as you start to become infected, your body starts to recognize that you have a foreign invader, a virus, and then you start to make antibodies against it. And the level of antibodies starts to rise. And so maybe after about 4 days after you become positive, you've developed a sufficient antibody response where your ability to transmit the disease starts to decline. And that's why in the early days, we said, you know, if someone is asymptomatic after 10 days of becoming positive or 14 days, they can go back to work, even without testing, because even though they may test positive, their ability to infect someone becomes very, very diminished. And again, when we talk about these vaccines, a 2-dose vaccine, you're talking about primary immunization, you know, and in pediatrics, we talk about the primary immunization for like diphtheria and pertussis and tetanus as 3 doses, 2, 4, and 6 months. All of those is still a primary. And then a year later, they get a booster. So in fact, when you get this disease, even if it's a dose of a vaccine or the disease itself, if you get re-exposed to it again, given these T cells that Dr. Graves talks about, there's a huge antibody response once you get that second exposure. So someone asked the question, should folks who've already gotten it get the vaccine? I think the answer is yes. And even though, you know, when we talk about getting that first dose, I believe, Dr. Graves, you can answer me, is that you become primed, and even if you get exposed to it, or if you get the second dose of the vaccine, your response is going to be great. So that first dose is going to offer some protection, but not the kind of protection that you get when you get that, call it amnestic response, where there's a huge amount of antibody that's produced because of that secondary exposure. And that's why they said, you know, after 3 weeks of the first dose, get the second dose, because that then is going to make you protected.
Yeah. So the first dose, you're right, is like a priming dose, and the subsequent dose is like a booster. And what we've seen from the Pfizer data, don't know what Moderna will show, the numbers were small, but it appears that after even one dose, you have like a 52% protection. So you're right. We don't want to make that into a big deal, because then people will say, I'm not going back for the second dose.
Right.
So we have to be careful how we say it,
Right.
you know? The other thing to know is that the second dose, again, is kind of a boost. People tend to have more severe reactions to the second dose than the first dose. Again, you know, the body's ready to respond, so it's not surprising. So to answer your question, Dr. Fredericks, I think Dr. Sprott did, and I agree with him. Even if you've had the natural illness before, there's no harm in getting the vaccine. In fact, it seems as though the antibody levels after the vaccine are actually much higher than the natural infection for most people.
Okay,
So,
Dr. Anderson.
if I might just add this, I think, you know, when we speak to each other, it's a different level of understanding. And I think when we start to talk about a therapeutic vaccine, that one that's actually prevents an illness is not the same vaccine that prevents an infection, right? And I think one of the problems the general public has is discriminating between the two ideas. And how is it important to get a vaccine that doesn't make you ill? And ultimately, how does that create the concept of herd immunity when we ultimately get to that critical 70% vaccination level? And what does that mean? Because if I can still go into the hospital not feeling well, but I can still infect someone who, even if they've had a vaccine, we're not sure where their level of immunity lies. So it creates an interesting conundrum with respect to understanding the process.
So Patrick, I think to your point, I don't think we know the answer yet to that, because I think that even though you might grow the virus from your saliva or from your nose and throat, it may be that that's not enough to make you that infectious if you've had the vaccine. But I don't think we know enough about it yet. You know, this is all very, very new. And I think the other question is, you know, and again, I don't know, I know that there was an attempt to try and get as many, you know, African Americans and Latinos into these clinical trials, but we're sort of reluctant to participate in the clinical trials. And so when you look at the numbers, and they talk about the safety and efficacy, there may be different safety and effectiveness in different patient populations. And my guess is that the numbers of Latinos and African Americans that participated in it, for the same reasons of fear about, you know, are we going to be harmed by it, might not have been as great. And so that then affects the reason that we might not have as large a participation in the actual vaccines. And so I think, though, you know, people are, as I said before, dying, especially in our community. And therefore, you know, I would encourage folks to get it because I think that, you know, when we talk about herding, we tend to herd together as communities.
Yeah.
And
I'm not raising the question because
where
I'm
we live
because
greatly increases the risk of infection.
right. I'm not.
Let me ask a question of Dr. Graves.
Because I'll be the first in line to get the vaccine. What I want the conversation to come around full circle is that even after we get the vaccine, and ultimately most of us will start believing in the vaccine, those same public health measures that we've taken to get to this point, we need to continue to double down on that so we can get over this hump.
All right. Dr. Atherley.
Yeah.
Can I say something before you start, Dr. Atherley?
Oh, okay, go ahead, Dr. Graves.
So I wasn't quite clear what you were asking, Dr. Anderson, but now I think I understand what you were saying, coming back around to the fact we need to keep doing what we're doing because it's going to take a while before we get to any level of herd immunity. To reach herd immunity, you need to have at least 2/3, and now we're saying more like 70% of the population who have immunity from the vaccine or naturally. We're nowhere near there. And most experts don't think we will get there until around the middle of next year or so. Now, it will improve as we come closer, but it won't be where we really want it until probably in the summer. So yeah, we can't ignore what we're doing and just say, yeah, we've got a vaccine.
Okay. Dr. Atherley and then
Yes.
Dr. Garrison.
Okay. I want to say, of course, that I will be happy to be among the first ones to get it when it becomes available to me, the vaccine, I mean. But one of the concerns that we've had is in relationship to the basic illness first. And that is that even in people who have apparently fully recovered from an episode of COVID, that there still is a question of lingering or continuing serious potential effects as a consequence of the immunologic response. And we have studies now, I mean, in my particular area, for example, we know that people who recovered fully, clinically, without any apparent sequelae of the disease, a significant number of these, in fact, a majority of these, may have demonstrable heart involvement. MRIs have shown in some volunteers 70% of them having an inflammatory response, a kind of myocarditis, which is not clinically evident, it's just a laboratory finding, but it may suggest, as a consequence of the immunological response, some continuing damage to cells in the body. So my question is this, if indeed this vaccine triggers off some form of immunological response, what assurance can we have that it will not be manifested as a damaging response to some of the cells in some parts of the body, which may not be clinically evident, but which may manifest with some very elaborate testing as continuing inflammatory responses involving these cells?
That's a very important point, and this is why we're still learning about this disease. You know, when we think we fully understood it, we really haven't. And the whole concept of long COVID or long haulers in this disease, now we know that 2 to 3% of individuals who are infected that we know about, and then there are the asymptomatic cases where disease was never evident and it's picked up just by routine testing. But the heart seems to be one target organ. The central nervous system is another, and even the pancreas. There are people who are developing diabetes because of pancreatic inflammation way months after. So I think this is ongoing stuff, and we still have to be willing to be open and to learn. And this is another reason we shouldn't take this too lightly. And I know it's difficult to persuade individuals who are of the mindset, I don't want to take the vaccine. I think we just have to remind individuals, we're still learning this disease, you know, 2.5 times more Black people are killed by this disease than white folks. This is not a joke. And 2 to 3 times more hospitalized. And when you're hospitalized, there are other bad things that happen to you besides dying from the pneumonia, you know, from pulmonary embolus or whatever, being in a hospital, nosocomial infections and so on. So I think we are going to have challenges. We're just going to have to divide the groups. There are those who are vaccine hesitant, who need a little bit more explanation. And those are the ones that we should spend our time with. There are those who are totally vaccine resistant, the naysayers, the anti-vaxxers. Those you're not likely to persuade. So I don't know. It's a bit art and science that the rest of medicine is how we approach individuals with this.
Okay. Dr. Garrison.
Just Trevor, I think this is just my thoughts, nothing other than that. I think that what we saw with COVID is a very intense inflammatory reaction, maybe 7 days into the illness, where a lot of the folks who were mildly sick then all of a sudden got very, very sick, especially with damage to the lung. And the question is whether or not that damage to the lung was related to an inflammatory response that involved the virus itself, or whether or not it's an inflammatory response related to antibodies that got formed against particles. We know very well, like strep, group A strep, how there's something similar about the antibody response against group A strep that can damage heart valves, right? And so we know that there's some cross-reactivity between antibodies that were triggering against that strep infection that damaged the heart. sometimes can damage the kidneys, strep. And so the question is whether or not the vaccine will prevent those antibodies, or whether or not antibodies will be cross-reactive to normal tissue. I don't think we know enough at this point. I think, though, the question is, if you take the vaccine and you might be able to prevent that kind of inflammatory response or from happening, you get it. Whether or not you can or not, I don't think we know yet. But I think that that's kind of the question as to whether or not you're talking about antibodies that might cross-react with normal tissue, either lung or myocardium or heart muscle or brain or other things. I don't think we know.
All right.
Exactly.
Yeah.
There's also some evidence that the virus infects endothelial cells. And that may also explain why there's inflammation throughout the body, because it's not just the lung tissue. If you're attacking endothelial cells, that might be another mechanism. I still think we're learning, though, really.
Yeah. Dr. Garrison.
You know, kind of to piggyback on what Dr. Athley and Dr. Graves have briefly talked about, I get two types of patients that come in the office. The hesitant ones who want to know more information, and then I get the other ones who are the conspiracy theorists, who believe that we never went to the moon, who believe the election was a fraud. All those are the people, and they want to try to convince me otherwise. And
Is
those
the president one of your patients?
Huh?
Is Trump one of your patients?
Yeah. He wants me to do a rectal exam. Okay. But my question is sort of going into the medical legal category and not the medicine. But as people get more and more inoculated, get more and more vaccinated against this disease, what do we do? Like I said, at my hospital, 30% of the physicians said they won't take the vaccine, and they're based upon the conspiracy theories, you know, that Big Brother is out to get us, and, you know, they're going to put chips in the vaccine so we can be tracked. Those are some of the things I've heard. What are the legal? Are there anything on the horizon, illegal, or even Big Brother say to those people that don't get vaccinated? What are the ramifications and implications of 70% of us getting vaccinated? And like Dr. Athley was talking about, those that are carriers and things like that. Is the government going to intervene, or where are we going with this?
From all my talking to my experts, friends, and lawyers, and looking at what's been done for influenza, we shouldn't expect the government to intervene to mandate this vaccine. I don't think that will happen. But as I said, employers individually will be able to do that, and they will take the consequences one way or the other, allowing for some specific exceptions that I alluded to before. So I think it might well be that the same kind of situation with influenza every year, there are always some nurses or one or two doctors who don't want to take the vaccine, and they end up working that out between themselves and the employer. I don't think this is going to be any different. I don't think we should expect the government is going to step in and say, everyone must get the COVID vaccine. It ain't going to happen. Not in the United States.
So what should I say to a patient down the road that says they haven't been inoculated or haven't been vaccinated against this, and they want to come in and my services? Do I have a legal leg to stand on to say refuse them services?
So I think so, but I'm not sure. That's something you would have to check with an attorney. But honestly, I believe that in a case like that, this is not an emergency where the person's dying. I suspect you'll be able to, but others can chime in.
Yeah, I can tell you
Dr.
that,
Graves.
as Dr. Graves said, the vaccine is not going to be mandated for anyone in New Jersey at this point. Employers can make it a condition of employment for you to receive certain things. And in the state of New Jersey, influenza vaccine is one of those things. They removed earlier this year the religious exemption for influenza. And so as a condition of work, you may be required to get the influenza vaccine, or you don't work. You can elect to leave. I think that when COVID first hit, the Hospital Association did a lot of work to try and protect hospitals from litigation against folks that might have acquired it. In the state, they made a decision that if you have a hospital employee that gets COVID, you can assume that they got it from their workplace. Now, everyone knows there's absolutely no way you can assume that anyone got it from their workplace or not, but they just made that. And you as an employer have to fight to see whether or not they did indeed get it from there or not. But I think that there's, you don't necessarily have a legal right to refuse to care for a patient that you've been caring for before. You can't abandon a patient that you've been caring for. You can require that person mask and protect themselves and you from getting infected. But I don't think that you can not see a patient because they don't get a vaccine.
You refer them though to another doctor if you don't want to see them? I thought that was in the law.
Well, look, I think that you can try and do things that allow them to have an options. But from a legal standpoint, if you have a patient and you have that doctor-patient relationship, you can't abandon that patient lightly. And I think that would be a circumstance that would be, given the ways that you can prevent yourself from getting infected and prevent that person from infecting you, you'd be on shaky grounds. I do have a law degree.
One question.
As well as the MD.
Yeah.
Dr. Greaves, I have a question.
Go ahead, Dr. Court.
Dr. Greaves, apart from those patients who have a severe allergic reaction to the vaccine, is there any other contraindications, like for the flu vaccine, patients who are allergic to eggs who cannot receive the
No.
coronavirus vaccine?
Eggs aren't involved in that's the neat thing about this vaccine, and someone I think touched on it earlier. There's some in the community, and you may have heard this already, who are against taking any vaccine that use fetal embryonic cells. And a number of the vaccines, other than these messenger RNA vaccines, do require propagation of the cells with a virus where we're using, vector viruses as part of the vaccine. So egg, no, that's not going. But at the moment, we're not recommending it for women who are pregnant because we don't have enough data. People below the age of 16 also because we don't have enough data. And now those with severe allergies or history of allergies, those are the ones that are now not recommended to take this vaccine.
But we do know that pregnant women have a much higher mortality than others if they get COVID.
Right. Yeah. In the ICU, we've had quite a few pregnant females with COVID. And unfortunately, the mortality is definitely there. There are several things, and I think from Dr. Sprocket mentioned certain things as far as the very critical patient with COVID. That hyperimmune response is real. We actually are trying to still determine how the lung or the other organs are involved. Initially, we thought it was number one infection, viral, and there's a diffuse interstitial problem there when you look at the CAT scan and the X-ray, that all lobes are involved. Whether there is the hyperimmune response is the problem and not truly an infection, or is there is there very small, I should say, put it this way, are there very small clots in the blood vessels that prevent the oxygen going from the lung to the bloodstream? And these are some of the things that we look at because there are so many effects of this virus when someone's really ill. Number one, their respiratory or their breathing is affected drastically that they need a ventilator. There can be strokes, meaning that there's a hypercoagulable state. Your blood clots more frequently and you can have strokes. The kidney failure, and most of these patients are on dialysis as well. And there are so many other things that are occurring throughout the body along with all of this. Any one of these can be fatal. And when you put this all together, and this happens rapidly, it's not like it happens over weeks or 2 weeks or 3 weeks. We're talking days and severely ill patients. So, Dr. Salam, I want to ask you and just digress just for a moment because we're starting to run out of time here. And I want to ask you in our neighborhoods, in the African American neighborhood, when we're talking about all of what we're talking about here, because this is the greatest conversation that I've had about COVID and this vaccine so this is so important. From our communities, how do we approach that such that our communities are comfortable? Because no matter what we say as a panel, our communities are not comfortable with this.
Sure. So number one, we have to do our due diligence, and then we have to make a decision as African-American physicians, whether or not we're going to take the vaccine. And I almost look at it as we looked at elections. And so elections usually boil down to a two-horse race. So you have to make a decision. Same thing with the vaccine. You're either going to take it or you're not. So I thought about this and I said, how would a non-medical professional think about this? And how could I convey the importance of taking the vaccine in a way that they could understand it? So the way I look at it is, we live in America. This is a capitalist society. And in order for the economy to run in the setting of COVID, you really have to boost confidence that you can go to movie theaters, to restaurants, to shopping malls, and you're not compromising your life. And so we know the importance of the almighty dollar in a capitalist system. So there's a very powerful incentive to create a vaccine that's effective to really drive this economy. And so what I'm saying is, this approach might be cynical, but if you look at it from that perspective, well, we know the importance of the almighty dollar in America. People want to be safe and they want to be healthy. They don't want to imperil themselves by going to a restaurant, the movies. Also, the folks who are developing these things, the man or the systems, they don't want their parents to die as well. They have similar fears. And so there's an investment, there's a huge reward, a financial reward, a systemic reward for developing a safe and effective vaccine. And so thinking that way, I think you have more inroads, because I know personally, I'm not going to anyone's movie theater. I'm not going to anyone's crowded restaurant. I'm not going to any crowded athletic event until we have this effective vaccine, we have this herd immunity, and we could approach life as we once knew it. I'm not sure we'll ever get back there, but I'm saying look at it look at the financial argument and look at it from that point, and perhaps you could gain more inroads. And finally, I won't take credit for this. There's a dynamic sister. I think she might work out of Newark. She's often on MSNBC. Her name is Dr. Chris Purnell. And what she's a physician and she's a public health expert. And sadly enough, her dad passed away from COVID. But one strategy she's used to connect to folks in our community is the power of narrative. And that narrative and stories resonate, because we're at a point where a critical mass of folks have passed, and we all know we're all connected in some way to someone who's passed. And so when you start putting it in terms of how it has affected your life and how it has fueled the grief in your life, then it makes it more relevant. It takes it from the abstract and into the concrete.
So,
Well said.
you know what I think? I think it would help if, say, we showcase people who have had the condition and ask them if they would take it again to prevent recurrence. And if people say yes, then that would encourage many more people to say, well, okay, if they could describe what they went through, and if they would want to go through that again, I know I wouldn't.
I
would take the vaccine. No question about
it. When you talk about behavior change, the the old adage of positive reinforcement as opposed to negative reinforcement, the fear of death. A lot of folks don't fear that they're going to die. A lot of folks fear that they're not going to get it. But I think that many people will be moved if you can convey the fact that there are important people in their lives that they possibly can prevent from getting it by getting the vaccine. Because I think that you know, when you start to think about the elderly as being most likely to die, and many have died, almost everyone's got old folks in their lives. As a matter of fact, all of us are pretty much old. And I think that people may be inclined, especially the younger folks, and that's where most of the disease spread is occurring at this point, might be more inclined to get it if indeed there is a belief that they'll be protected, their own family elderly, as opposed to anything else. Even within the Black community, that might be important. But I think that some of the arguments, and again, Dr. Salam, a financial argument might be a little too abstract for some folks in terms of making that individual decision. But I think if you can sort of personalize it to loved ones that they might be protecting or helping by getting the vaccine, that might move some individuals.
Mm-hmm.
What I wanted to say was that the National Medical Association, the National Black Nurses Association, the National Urban League, they're working together with the key people at a number of the historically Black medical schools, Drew, Howard, Morehouse. They've been having several meetings within the community with their fellow physicians and healthcare workers to help spread the word. And in addition, I know that there are several Black churches who are doing exactly what you're suggesting, Dr. Court, where in their congregation, someone has come down with illness and survived. The minister or pastor of that church has sometimes had sessions where they've had a show and tell kind of thing. And that is very powerful. You're right.
Mm-hmm. Yeah, definitely. What we're going to do is, do we have any last words with this? We are almost out of time.
I just wanted to perhaps make a comment and see whether Wayne would want to, Dr. Graves might want to comment on this. Okay. I think there are two components to the getting of this vaccine. One is the self-preservation, that we do want a vaccine to protect oneself. But I think what we do, and I feel very confident and convinced of that, and we'll certainly line up to get it. But the other aspect is the confidence that I will not be able to carry the illness and transmit it. I think there is no way that an employer could enforce one having the vaccine if one could come back with the argument to the employer, well, even if I have the vaccine, I still can carry the virus and infect others, maybe our patients, or infect others. So what is the point in you're forcing me in that way? So that may be an argument against the employee, etc. But I think from the point of view of ourselves and our families, we want to have the second aspect answerable and answered. That is, can we still pass the virus on if we ourselves are protected from having the virus invade our own cells? How long do you think before we can get that kind of answer, Dr.
So this is a key issue right now. As I alluded to earlier, we don't have the answer. The AstraZeneca study of the 3 vaccines that are currently available or almost available, that is the only one where they kept doing testing after they got the vaccine and not just waiting until you came down with the full-blown illness. So I think the data from the AstraZeneca vaccine will probably be out early next year. They've published something very brief, but that was to do with the mix-up with the doses, the low dose, high dose stuff, looking at the different efficacy, but they haven't gone to that level of detail. But that's what we really need to have before we can make the argument pro or not taking the vaccine, as you alluded to, Dr. Atherley. And the one more thing I want to say before I forget is that the efficacy of the Pfizer vaccine, at least, based on the review that was just done by FDA, shows almost identical efficacy across different ethnic groups, different age groups, which is reassuring. Numbers weren't large for the reasons you've already mentioned. We don't like to participate in trials, yet we complain. So, but based on what they got, I think 10% were actually African-American, and the efficacy looks good. So we can take some comfort in that.
Excellent. Excellent. Yes, Dr. Salam.
Also, as African-American physicians, I know we occupy an important position in our community. And whether we like it or not, people will look to us for leadership on this. And it puts a lot of pressure on us to get this right. But, you know, you're between a choice of fighting by getting the vaccine or being passive and not getting the vaccine. And moreover, we're going to have to make a decision pretty quickly because we'll be among the first to get the vaccine. So if like me, you have a punitive superego or conscience, I don't want to be in a position like this where I've made a really suboptimal choice or a choice that's really not ideal, knowing that I'm in a position of leadership, and then their lives, there's morbidity, there's mortality, there's lives that could have been saved as a result of taking leadership on this or not. So just knowing the position that we all occupy in our community, it's really important that we demonstrate leadership on this. And it seems like the data is pretty solid. And so I'm prepared to stick my arm out and take the vaccine and evangelize about this, about this effort, particularly in our communities.
Yeah. I also think that we're talking about the community a lot, but we're not talking, I don't think we've expressed the deep thought that physicians themselves have maybe needed to take or have had to take to come to that decision to take the vaccine. Let me explain. I look at it as the devil that I know and the devil that I don't know. And the devil that I know means that I make rounds in the ICU every day and in the hospital every day. I'm at that age that I could be exposed and have a very bad result. So that's the devil I know. But the devil I don't know is that what is the long-term effect of this vaccine? So because it just hasn't been around long enough to us to really know what's going to occur to all of the people over the world who will get this vaccine. So I think we can extrapolate that out to the community too, as well. If I come in contact with someone with the virus and I get the virus, there's a possibility I may die. I don't want to take it, but I'm going to take it. You understand what I'm saying? So it's very, and as physicians, I think we are, it's to the forefront. We're on that line that we're facing it every day. The psychological aspects from a physician's point of view. Can you address that, Dr. Salim? I know we're coming close to the end of the program. We're going
May I just ask one quick question before we answer that? And that is, it would be a very strong point. We have the community watching us.
Yeah.
If the community could hear, there were 4, 8, and 2, 10 physicians and one guest, 11 physicians on this program, and such a percentage said, yes, we would take the vaccine. So we can let you know, Dr. Bay, so you can quickly announce what percentage of us would take the vaccine. I mean, if 100% of physicians on your program said yes, that says something to the community. So do you want to ask us and get a quick poll? Ask us. I don't want to embarrass anyone who will not get it. That's why I don't know how subtle you will be in the asking. Right. But if you ask simply...
with the hands being raised, it looks like most of us would do it anyway. We don't need to do that, but... and I didn't really want to put us in that position.
No, but that's why I said if it's something we can let you know by flicking on and off something that you would know, not everyone.
Trevor, to your point and to Patrick's point earlier, the thing that you most want to have happen is never to contract the disease.
Right.
And the issue is that how many folks got the disease because they didn't social distance and they didn't wear a mask. And our president sort of downplayed the severity of this whole thing. And so if you've been lucky enough to not get the disease because you wore a mask, you ought to seriously consider the reason that you wore the mask in the first place was to not get it. And therefore the vaccine is something that is very important to helping you not get it.
Mm-hmm. Yeah.
So there are things, Omar, there are things that I saw that I cannot unsee. And there's experiences that I've had that can't be undone.
Right.
And during the height of the initial pandemic, there were times when I questioned the Hippocratic oath, meaning I needed to come in. I know the hospital was on lockdown. to operate emergently. And I had to get up and say to myself, for the better good, and it's not about being magnanimous, but it's being fair to the process and to what we've committed to do.
Right.
I go in, you wash your hands, you gear up as best you can, and you hope for the best.
Right.
Some of our colleagues have not been so lucky.
True.
Those are the experiences I cannot unshare. So with that said, if I have an opportunity to protect if we have an opportunity to protect ourselves so we can keep doing for the community what we're committed to do, then there's the answer.
Yeah, I agree. I agree 110%. You know, you think back and when this virus in March and April, at the hospital that we are, over 90% of the hospital was COVID. Every ventilator in the hospital and every ICU, every monitored bed, no matter if it was in the ICU, recovery room, and same-day surgery, no matter where it was in the hospital, it was filled. And every day, each and every one of us came into that hospital and exposed ourselves to potential harm. And so the thing of it is that I understand what you're saying. I was just coming from a psychological point of view of our stability as physicians, because we're people too. Don't think that we're robots. And, you know, I don't think that if I walk into this room, that there's a chance that I may not, because we did lose physicians. We lost good friends, and we'll never see them again. But, you know, good colleagues, excellent physicians are gone. So it's real. And I just was trying to relay. Yeah.
Listen, I tell people I was Kareem Salam a long time before I was Dr. Salam. Okay. And so, despite having taken the oath, I don't think any of us went into this to die. Okay. None of us expected to be in a position where, you know, you're considering your own mortality during your commute to work. So what you do is you follow the recommendations, you gear up, you wear your PPE, you do the best that you can, but in the spirit of self-preservation, you have to self-assess and you have to realize this when you're not doing well. Why? Because you're facing an abnormal situation, a once in a century event. And there are some of my colleagues, especially the ER folks, the pulmonary critical care folks, and the support staff who work in these environments, they're seeing an unstoppable tide of death. And this is completely abnormal. There will be a massive epidemic of PTSD. Folks coming to work, and before they get to the site where they practice their craft, they're passing these refrigerator morgue trucks. Okay, so at some point you have to have a good sense of when you've reached your limit and if you have to tap out. So, you know, if you have a day off, by all means take it. One thing I say is vacation for me makes me a better physician. And when you're off, you really ought to divorce yourself from your workplace if you can do that. There's no point in taking a day off and you still have your pager on and you're still responding to calls, because guess what? No matter what, we all know this to be true. Those patients are going to be seen. Somehow, some way, those rounds are going to be made. Who's going to love your child? Who's going to husband your wife? Who's going to be pop to your grandchild? So you can't completely forget about those obligations as well.
Right. Thank you. I saw Dr. Patrick Anderson smiling when you said tear off your beeper. Dr. Garrison, you had a question.
Oh, no, it's been answered.
Okay, all right. Number one, I just got to thank all of you physicians for coming on today. I mean, this was wonderful. And number two, I got to beg to apologize to a lot of the audience because a lot of questions came up that we did not answer. Please come back next month and the month after that. We will answer your questions, but this is a crisis in our community with this COVID and the question of taking the vaccine. We had to address it. Dr. Graves, I would like to please give us a final thought as far as this is concerned.
So I think we have to keep in mind that we are leaders in our community and that our patients in the community in general look to us, and we have to be very careful about what we say, how we say it, and where we say it. And so that means that we should think ahead in response to the whole COVID vaccine issue and, be prepared to engage with those in our community to do whatever we can in whatever way we can.
Okay, thank you. Again, thank you all the brothers who are here today. It was a wonderful webinar. Let me end out by saying thank you to OBHealthy for allowing us to use their platform. They're a weight loss app. Just go to your app store and take a peek at it because we as a community need weight loss for proper health. I will now end with that statement. Remember, the second Saturday of each month, we're here at 1 o'clock. So tell friends and family. And the last thing I'm going to say, do not change any aspect of your medical care until you consult your physician. It's so important because only your physician or your healthcare member knows your body to the point where they can properly advise you as far as being healthy and what medicines to take. Number one. All right. It takes a village. Remember that. So share the knowledge. All right. And after that, I'm just going to say peace. And I love you all you brothers for coming on. And we will see you next month. Second Saturday of the month, 1 o'clock. Peace.
Bye.